All right, so in about 10 minutes, we are going to talk about an effort that we embarked upon in January to support COVID-19 patient management with data at Stanford, and specifically how in the Innovation and Translation team at Stanford Technology and Digital Solutions group, we stood up a clinical data science team to get answers about patient management in just 2 weeks. I'm Alison Callahan. I'm a research scientist in the Center for Biomedical Informatics Research, and I'm co-presenting with Jose, who many of you know very well for his ongoing excellent work here in OHDSI. This is work that was done by a very large group of people, including EMR data specialists, clinical informatics fellows, clinicians, and the Department of Medicine Task Force on COVID Clinical Guidelines, who were our driving clients, so to speak, in this setting. So the context of this work is that in January, Stanford was experiencing a surge of COVID patients, including transfers from other hospitals where there were not beds available. And this required the team to be ready to make quick but informed decisions about how to care for patients with COVID, and specifically how to keep patients in the hospital who were still sick and needed management, but also discharge patients who were safe to go home in order to maintain hospital capacity as we managed the surge. And specifically, the team needed evidence to be able to assess when it was safe to discharge patients on home oxygen, how to safely manage patients with high flow oxygen needs on the floor, and also how to risk stratify for complications of COVID, like venous thromboembolism.
So the process we used for this question was, first we needed to formalize these questions in a way we could identify clearly where the population, where the intervention that we wanted to capture, where the population we were to compare to, and where were the outcome. That process was formalized with the entire team when we went over the questions, and then we formally defined the cohorts and which variables we needed to be sure to capture, to reliable capture, to be able to answer those questions. Then we pulled the data for the corresponding, for each one of the cohorts. We, of course, at this moment, one of the things we want to highlight is that we use a combination of the STAR OMOP, that is our data in the OMOP CDM, and our Clarity data, that is the raw data we have at the hospital. And then we sanity check the data and we conduct the analysis to review this question. The sanity check process will be very interesting. We'll be talking a little bit more about later. And at the end, of course, we need to communicate this. We write a report and summarize our findings with the entire stakeholder community that were involved in this effort.
And we aimed to do this in sort of as few days as possible per question, 1 to 3 ideally. And with this design, we sort of tackled 4 questions. And I'm going to walk through the results of specifically the second, which was among adult COVID positive patients who had high oxygen needs, what was the rate of transfer to the ICU, and what was the rate of intubation or mechanical ventilation in that group. And the context here was an interest in understanding whether the current threshold of oxygen need that was being used to initiate transfer to the ICU was appropriate, or whether it could be relaxed in the case of constraints on ICU capacity. And this required us to translate this question into a question formulation of the PICO format that Jose outlined, so that we could then execute queries over the OMOP CDM instance. And so here, that translation into our question formulation, into our cohort definitions, looked like this. So if you just want to do one more click, perfect. So we basically translated that one sentence question into this longer, more detailed version, which is among adult patients that we defined as 18 years old or older, admitted with a COVID-19 diagnosis a day before their admission or during their stay, or who had a positive SARS-CoV-2 test result within that 2-week period, and who did not have a do not resuscitate order, received at least 6 liters per minute of oxygen at any time, because that was the threshold for transfer to the ICU. How many of those were transferred to the ICU, and how many of those patients were intubated or placed on mechanical ventilation? So that was sort of our walkthrough, our logical process to go from question to cohort definitions.
And then we, of course, started with Charybdis. So Charybdis actually gave us, for Start OMOP, a good starting point to define a cohort, what COVID positive patients were. We started from that phenotype definition. We refined it a little bit to like just pinpoint the question that Alison was pointing out. And then we also use our raw data, that in this case is clarity, epic clarity, to go and get some of the variables that for some reason were not present in our Start OMOP. And we will go into some of these very interesting reasons at the end of the presentation. But then we did a combination between what we have in Start OMOP, what we have in Start in Clarity. And for example, one of those interesting variables was the do not resuscitate orders, which affects heavily what you see in the patient, because you may sometimes see a patient in the ICU and then you don't see them mechanically ventilated. And this is usually the reason why that happened, because of that directive. And those set of variables were merged in a single data set using a unique patient identifier. And we can just also highlight that the fact that we could actually combine the OMOP CDM with other sources to answer this particular question. We already mentioned that we use the Charybdis phenotype as the starting point. And as we said sort of on internal trainings, the approach for OHDSI for phenotypes is copy and paste and then refine.
And so after we used the Charybdis phenotypes and pulled that data set, merged it from the OMOP data set with our Clarity data set, what we found was that 14% of patients with high oxygen need, that is corresponded to about a third of those patients who were transferred to the ICU, were later intubated and placed on mechanical ventilation. And the task force interpretation of these findings was, because that proportion was relatively low, they felt comfortable being ready to change the threshold of 6 liters of oxygen per minute for ICU transfer in the case that ICU capacity was constrained. So this is one example of an answer to a question and how it was used by the team as they managed the surge.
So of course, when trying to do this very rapidly, there are many challenges we face. One is that at the beginning of the pandemic, we actually saw some COVID diagnosed use for actually not really COVID patients, but sometimes to justify the lab test. Of course, we were using some flow sheet data to get accurate representation of the amount of oxygen a patient was receiving, and processing this data. Of course, we needed a good backend infrastructure and code to be able to process these millions and billions of rows for every single patient. Also, trying to pull relevant ventilation information. This was very interesting because the way the workflow is managed, those ventilation orders are actually routinely canceled, which was a very interesting finding of why sort of this representation of these orders was not all the time were represented in the CDM, because we usually try to filter out events that are actually canceled, but the nature of the workflow makes that almost every single order gets canceled at some point. And this was a very interesting exercise when we engage in real-time chart review literally we were coding, and then the clinical experts were reviewing charts to see if the variables we were checking were actually in the chart and whether those variables were plausible for the set of people we were seeing, and tracking down, as we mentioned before, this DNI, DNR order, because patients that seems to be in ICU doesn't seem to receive some of these intensive services, but because of a directive that is expressed by the patient. And this, I know, this may not be the case for every country, but for this country, these orders are very important, and even in this context, they are issued by the patient side.
So the takeaways, in addition to the results of the analyses that we conducted, were that for clinicians on the task force, data summaries were helpful, independent of statistical analyses. So in several cases, the number of patients that we were working with were small, which is fortunate in our case, because that was an indicator that few patients with COVID were in rough shape. But we still needed to be able to provide useful information to them. And in this case, summaries alone even were very useful. As I imagine many on this call won't be surprised, 80% of the effort in this 2-week period was getting the data pulls done, writing the queries, using the Charybdis cohorts properly. And then the analyses using those data sets were the easy part, relatively speaking. We estimated across our team, which was about 5 people working really in a dedicated way, about 300 hours of collective effort in a really short period of time. And this was a really excellent collaboration, and it relied on the excellent communication of the team and being able to sort of work long hours and work late. It was wonderful. And our use of the STAR OMOP data was essential to the success of this project. And our ability to link it with Clarity data was really powerful and useful as well, but also identified places that we would see potential for changes to the way we have data in our STAR OMOP instance, as Jose kind of indicated, especially when talking about orders, which is particularly interesting. That's all we have. We'll be happy to take questions at the end. Thanks.
Great, Alison and Jose, thank you very much for that great presentation, all the work you led. I know there's a question for you guys in the chat if you wanted to take that. And we'll go over to Lisa now, who's going to talk to us about work at UC Colorado Denver.